session, and the first talk is uh, by Dr. Muhammad Samir, diabetic macular traction.
Thank you very much and good morning, my dear friends. Okay, I will speak today about the diabetic macular traction all weapons. Diabetic macular traction is a very important entity in the diabetic vitrectomy, and we have many weapons to attack the diabetic macular traction. First of all, this trick is to open the posterior hyaloid when it's taut posterior hyaloid with the epiretinal or epimacular membrane, just to make an opening in the center of this taut posterior hyaloid with the membranes, with the epiretinal or epimacular membranes, and using the shaving mode of the cutter. I always do the shaving mode in these situations. The shaving mode is about 200 millimeter mercury, about 5,000 to 7,000 cut per minute, and we can segment this broad adhesion. This is what's called broad epiretinal adhesions, which is difficult in dissection. So by using the cutter and snagging the membrane like this, by cutting or aspiration the membrane all over the plan of cleavage. The most important step here is entering the plan of cleavage. Entering the plan of cleavage is the key success in these cases. Without entering the plan of cleavage, you will make an iatrogenic break, and that's not very favorable in diagnosis to the patients. If we're going to see about the bleeding here, to control the bleeding, we can raise up the infusion bottle. We can raise the intraocular pressure to 30 or 40 millimeter mercury. And while moving and snagging the membranes or the posterior hyaloid residuals, I should look at the attachment centers or the epicenters, because at these epicenters where the iatrogenic breaks happen. At the end of this case, as I told before in past presentations, no need for internal tamponade. Just I leave the patient on air in this case because there is no breaks. Another attack is using the unimanual dissection with BIC. This is also diabetic macular traction with broad adhesions, starting with the PIC, raising the epicenters as we are going to see here, and cutting the epicenters by the shaving mode, which is more safe in these cases, just to prevent iatrogenic breaks and control of bleeding by elevation the intraocular pressure. And some people or some surgeons prefer to inject anti-VEGF before the operation by 24 to 72 hours. Sometimes I do this, sometimes I don't, because this case I didn't inject because it's totally fibrous tissue. So when it's fibrous tissue, no need to inject. When it's fibrovascular tissue, you can inject, and you can inject before the surgery by brief time, 24 to 72 hours. And you should be sure that the patient is admitted or the patient will come to make the operation, because it will enter in tractional detachment if he doesn't come. Another way to attack the epimacular traction or the macular traction here is the bimanual with the cutter and forceps. Just elevating by the end gripping cutter the membrane or the fibrovascular element, and entering in the plane of cleavage by the cutter as it's shown in the video. It's a very safe, and it's at the same time it's a rapid maneuver to remove just the membranes. All these hemorrhage, one of the tips in these surgeries, Don't keep the hemorrhage for a long time on the retina because it will be clotted and it will be difficult to get it out, to aspirate it. So try to aspirate as soon as possible this amount of blood, and when you work, please raise up the infusion bottle. Another tip in these maneuvers is the light pick. It's by manual using a pick which is a light, is enlightened, so it's a light pick at the same time, so no need for chandelier light. Using the light pick is very nice tool in these complex cases. Elevation the epicenters, as we are going to see in the video, and entering in the cleavage membrane. I can remove all the membrane, and I can do as well as segmentation. No need for removal of all of the membrane if I can't, just segment. And we can use the internal diathermy to cauterize the peripheral ends of this segmented membrane, so converting it from fibrovascular to only fibrous tissue, and we can leave it in place if it is not exerting any traction on the eye, on the retina or on the macula, as we see. One of the disadvantages of this pick is the light scatter. So if I hold it in the opposite way, it will work as a very nice light tool, and there will be no light scatter in the eyes of the surgeon. And at the end of this case, I left the patient just on air because we don't have brakes. This is a nice case of macular fold. This is a macular fold due to macular traction, epiretinal membrane, as we are going to see now. Dissection by forceps and scissor. I like the horizontal curved scissor, and I recommend the horizontal curved scissor in these cases because it can enter in the plane of cleavage easily and more steadily. At the end, after removal of most of the membrane, a tough part of the membrane can be removed by the cutter. And I will do in the next step ILM peeling, and as we are going to see now, the macula is not in place, it's elevated. Okay, there is submacular fluid still, and for the surprise of us, this fold will unfold on the table, and this happened after removal of the epiretinal membrane and after doing the ILM. So there is a question here. There is submacular fluid. What I'm going to do with this submacular fluid? No need for internal drainage of this submacular fluid. This submacular fluid will be absorbed spontaneously without doing draining retinotomy in the retina, and that will go easily, but it will take some few time. This is another interesting case of epimacular traction. This is the macular traction. This is the macula with submacular blood. There is submacular blood because it's a case of PVR on top of PDR. So removal and the retina, of course, is detached. I'm working on a detached retina. Some surgeons or some people recommend to put a third hand. The third hand is the PFC. PFC in these eyes will stabilize the retina during the dissection of the membrane. It's a good idea, of course. Removal of the peripheral broad adhesions is difficult in diabetic patients, and as we see here, this is the rest. This is the optic disc. This is the rest of the membranes, and here will be a tough subretinal band, and this tough subretinal band should be attacked, and I will show now how to tackle this subretinal band. Just removing by the shaving mode, as I told before, and raising the infusion bottle to decrease the incidence of intraoperative hemorrhage. Removal of these fibrous traction membranes will make it easy for the retina to go back to the choroid and to rest in place. To attack this part of the tough subretinal band, doing diathermy on it, and trying by the serrated forceps or end gripping to grasp it, but grasping it and removing it in this way may cause more harm in widening the retinotomy. So here I use the third hand, which is the BFC, and using the BFC acts as a cushion and as well as a third hand, so it's easy to cut it. No need to remove all the band and to go for it. Okay, just cut it, the retina will come and relax in place, and in this case I used silicone oil injection. So my take-home message is you can use all weapons. You can use the pick to elevate the posterior hyaloid. You can use the tip of the 3 centimeter syringe as well, and you can work with the light pick, or you can work manually with the cutter and forceps, or forceps and scissors. Chandelier light in this case is very important and mandatory to work with bimanual techniques. And the concept of putting internal tamponade, we should come to an agreement that if there is no breaks, no need to put silicone oil or even gas. If there is no breaks, just you can leave the patient on air. This is one. The other thing, if there is a superior break, you can use gas, tamponade, and if there is inferior break, silicone will be the good choice for this. Thank you very much for your attendance. Thank you very much.
Thank you very much, Samir. I think we will have the questions at the end.
Any questions?
Okay, we can have one quick question if you want.
Hi. Thank you very much. It was absolutely fascinating to see how you manage these very, very difficult and challenging cases. I just want one quick question. When you segment and you leave behind small little fibrovascular tufts, I mean, do we need to remove them completely? Because sometimes there are very juicy vessels at the end and they can bleed even when you are cutting them, segmenting them. And so how do you leave the stump a little bit, or do you always try to remove it as much as you can?
This is a very good question. Leaving the stumps after segmentation, after doing segmentation, you should cauterize the periphery of these stumps if it is fibrovascular. So if it's fibrous, you can leave it in place. No worries about it. But if it's fibrovascular, you can either get it out or remove it by segmentation or delamination, or you can leave it if it's difficult, but you should cauterize the abnormal blood vessels on its surface or at the periphery of it, so that you will decrease the incidence of post-operative bleeding, post-operative vitreous hemorrhage, post-vitrectomy vitreous hemorrhage, and at the same time, you will decrease the incidence of further traction on the retina. Thank you very much for your question.
Thank you, Dr. Samir.
Thank you very much.
We can have more question at the end if someone has. So we invite the next speaker, Dr. Osman. He is going to talk about vitreous hemorrhage management.
Bismillahirrahmanirrahim. Good morning, everyone. Vitreous hemorrhage, obviously, as a vitreoretinal surgeons, is one of the most common problems we see in the clinic. So this is just a very simple talk to, actually it was directed towards more for the trainees or residents, that how to approach a vitreous hemorrhage in a patient where you don't know the pathology. But anyways, I'll start. So obviously we know the vitreous hemorrhage. It's important to, first of all, isolate the location of the hemorrhage. As we understand anatomically, it could be an anterior subhyaloid. It can be intragel hemorrhage. Intragel hemorrhage itself can be either diffuse or clotted and can affect the fundal view. It can be obviously subhyaloid or pre-retinal, which can affect the macula or maybe just below the macula, not affecting the vision. Usually, the patient gets a sudden painless loss of vision. It can be unilateral, bilateral, but usually it is unilateral. So when we approach this patient, what we need to do? Obviously, we need to stick to the basics. We need to check the vision thoroughly in both eyes. Intraocular pressure check before dilatation. Look for rubeosis. I forgot to put this. So look for rubeosis before dilation. Check the RAPD before dilation also. And we need to know a detailed systemic as well as ophthalmic history, because most of the times you will get the clues during that history. And also, not to forget, to get a detailed medical history as well as regarding the medication, especially for the blood thinners. The vitreous hemorrhage obviously can be related to many things. The simplest could be a PVD related. It could be traumatic. It could be a vascular retinopathy related to diabetic retinopathy, vein occlusion, sickle cell, etc. It can be related to macular degeneration in a breakthrough manner. It can be inflammatory related to uveitis, Turgeon syndrome, as we are all well aware of, and Persner's or shaken baby or Valsalva retinopathy in an extreme cases. So when we approach this patient and we have a dilated examination, we can have a view or there is no view. If the view is there, it could be a dull or diffuse where the fundus can be barely visible. You can see just optic disc gross details are present. Or it could be central with the good view of the peripheral retina, but the macula is covered. So just a few lines about the hemorrhagic PVD. I think we will all agree as physicians that probably keeping the diabetics aside or other retinopathies associated to the vascular problems, this could be one of the most common scenarios we see in the clinic. So if there is vitreous hemorrhage and you've ruled out any other retinopathies and blood thinners, it's important, obviously, depending on the view of the fundus, a kinetic B scan will give you a good idea when you ask the patient to move the eye up and down, right and left, and you can see the vitreous moving and there is no attachment to the disc and there are hyperintense signals. So it's been noted in the literature that PVD with vitreous hemorrhage is associated with 70 to 95% with horseshoe tear. So this is quite alarming, that if you have a vitreous hemorrhage where you don't have a fundal view, there's a high chances there could be a horseshoe tear there. Or PVD alone has 10% risk of horseshoe tear, but the risk increases up to 80 to 90% in case of bleeding. So if there is no fundal view, it should be treated as a macula-on retinal detachment with presumed horseshoe tear or any other tear, because if you leave it too long, the retinal detachment will set in with higher risk of PVR in the presence of the hemorrhage. So approaching this patient, if the retinal tear is visible or reasonably visible for urgent retinopexy and cryo, it can be done if you are quite confident that there is no other break. And then a close observation, possibly weekly observation, would be sufficient for a few months until the view becomes completely clear or the vitreous hemorrhage absorbs. If there is a superior retinal break, if you see it on the B scan, you can position the patient upright for 24 hours to see if it becomes more visible, reduce the patient's physical activity. If it becomes visible enough, then we can proceed for laser and cryo. If not, then we need to proceed for the vitrectomy to prevent the retinal detachment to set in. If there is no retinal tear visible on the ultrasound, there is thick vitreous hemorrhage on B scan, then it could be a tricky situation and need to discuss with the patient. And normally, I would consider an early intervention, keeping in view of a high chances of some retinal break which is not visible. So moving on to the traumatic vitreous hemorrhage, trauma itself can induce obviously a lot of intraocular bleed, which could be in the anterior segment as well as in the posterior segment, pre-retinal, subretinals, and subhyaloid. It could be a blunt trauma, it could be a penetrating trauma. In case of blunt trauma, if the B scan is showing no imminent threat to the retinal detachment, then close monitoring can be done on weekly B scans until the fundus view becomes clearer and you are more confident that no threat is there. But if there is no improvement for a month and the vision remains down, then exploratory vitrectomy could be carried out. The vascular retinopathy related vitreous hemorrhage, obviously that's one of the most commonest ones as the surgeons we come across, especially in diabetics. So if there is a vitreous hemorrhage on the B scan is showing no traction, then an anti-VEGF can be commenced with a loading dose and one can watch them closely. The other eye's retinopathy situation can give you a clue. So that's a very important thing, that not to underestimate the pathology in the other eye, but which can give you a lot of clues. If there is no improvement or little improvement in 4 to 6 weeks, then vitrectomy can be offered, explaining the patient regarding the pros and cons, risks and the benefits of the surgery. But usually the patients are usually tilted towards the surgical option rather than just observation. However, there is an element of traction you see on the B scan, especially in and around the macular area. Then early vitrectomy is indicated, possibly without anti-VEGF, but if you want to do an anti-VEGF, then within 24 to 48 hours, I would recommend to do the surgery to prevent the further worsening of the traction or creation of any break in the retina. So what is the therapeutic approach in these cases? If you have an evidence that there is pre-existing pan-retinal photocoagulation done, then there's no need to rush. You can close, or you can do a close observation and surgical intervention on the basis of vitreous hemorrhage, amount, and the location of traction. If there is a recent anti-VEGF, then again weekly B scans with close observation, strict excessive physical activity, good glycemic control is recommended. Posture almost upright with sleeping with 3 pillows, 2 to 3 pillows, no delay in surgery if there is an evidence of traction increase. And in cases where there is no previous treatment and no history of previous treatment, anti-VEGF for surgery depending upon the traction and the amount of vitreous hemorrhage. Now moving on to the macular degeneration, AMD-related vitreous hemorrhage. It can be subretinal, it can be mild, obviously intraretinal RTPA and gas with close monitoring with multimodal imaging. If there is a dense vitreous hemorrhage, then it can be combined, especially the breakthrough vitreous hemorrhage, it can be combined with or without anti-VEGF, and macular surgery with macular translocation in extreme situations. Just a quick mention on Turgeon syndrome. Luckily, it's not very common. It's a very rare cause. History is very clear with intracranial or subarachnoid bleed, confirmed on radiological imaging. Normally settles without any surgical intervention within 6 to 8 weeks, rarely with persistent non-absorbing vitreous hemorrhage in a patient who are already in blood thinners will need vitrectomy. There's no role of anti-VEGF in this situation. So just coming to the end, the important things are that careful examination is the key. Never underestimate a thorough dilated fundus examination of both eyes. Close monitoring can be done if there is no evidence of any imminent threat to the retina on B scans. No need to rush for surgery. Role of anti-VEGF only considered in line with the internationally set guidelines. And I must emphasize that anti-VEGF is not the answer for every vitreous hemorrhage. It is very, very important. So just a quick video, nothing fancy in this, just showing a vitreous hemorrhage clearance, which I normally start. I hope it runs. So, I mean, I normally start with the anterior hyaloid an anterior hyaloid clearance, because normally if there's a dense vitreous hemorrhage, it's very dangerous to just go towards the disc straight away. So it's important to get the view clearer, make the view clear as much as possible. Removing the blood from the periphery once the retina starts becoming visible. Here the B scan is important. Before the surgery, you need to make sure that you have complete information about the retinal status, that it is not tractional if there is not elevation, so that sometimes it's very difficult in a very, very dense, old, organized vitreous hemorrhages. It is very, very difficult to differentiate between an elevated retina and the vitreous hemorrhage itself. So once you have gone through the vitreous hemorrhage, retina becomes more clear. Then you start the peripheral shaving, and I try to do it as meticulously, as thoroughly as possible, because I don't want to leave behind the blood-stained gel at the periphery, because they would continue to throw RBCs in the vitreous cavity, results in post-operative vitreous cavity diffuse bleed, and also the higher chances of ghost cell glaucoma. So I think extra time spent here is vital. And obviously, as you know, if there's a vascular disease, and you treat it accordingly. And if there is no PRP, like in this patient, there was no sign of any laser done before. So once you are inside the eye, that's the best chance to do the as complete and thorough pan-retinal photocoagulation as one can do, because otherwise you will not get this opportunity. So I start from the middle or the posterior pole, go up to the periphery, and I am quite keen to do indented peripheral laser up to the aura, so that I'm pretty happy that it's all done up to the periphery. Then finish off with internal search to make sure that there is no residual blood-stained vitreous jelly present. And normally in these kind of a cases, especially this one where there was no traction, no membrane, nothing, straightforward air fluid exchange, and we finish off the case. Thank you very much.
Thank you, Usman. Just a comment. What about the management of lens? How would you, about the lens, would you remove it during surgery, or any rationale for that? Because most of the people are around 40 or 50 in type 2 diabetics hemorrhage.
Well, I mean, my threshold is, especially in diabetics, is low. If there is a cataract, yes, I would like to remove it. I'm not too keen, especially if somebody 50, 55, 60, when you already see there is a cataract developing, then it's always better in my hands, in my view, to remove it, to give you more opportunity to do a thorough peripheral examination, laser, anything you want to treat peripherally, because otherwise they're going to develop cataract anyway. So yes, my threshold is low. I usually combine it if there is, but if the lens is clear, there is no evidence of any cataract whatsoever, then certainly I would like to preserve it. Also, if somebody is high myope and the other lens is also clear, so therefore I do not then would like to create any anisometropia in these kind of cases. So it's a selective thing, depends. But yes, my threshold is low.
So, any comment? You can have one question. Okay. So thank you.
Thank you.
Thank you, Usman. So we go on to the next speaker. Dr. Amir Asrar is going to, Amir Awan, sorry, is going to speak on 27 gauge vitrectomy in diabetic vitrectomy. Sorry, Amir, for the.
Assalamu alaikum. Let's start. Right, so I think we are talking about the diabetic cases here, and we have to keep in mind traction retinal detachment. It is vision threatening, especially it's involving the macula, and most of the time then we have to do vitrectomy to sort it out. So in 2010, Oshima first time reported a successful use of sutureless 27 gauge vitrectomy. And since then, it is gradually gaining popularity, but not as popular as 25 gauge. So if we look at the Alcon data from last year, around 20% of the people have shifted to 27 gauge vitrectomy. So previously we have also published our data of around 665 eyes in which we performed 27 gauge vitrectomy, and we found very good safety and outcomes in those patients. So here basically we are going to identify how is the safety profile and outcome in the patients of traction retinal detachment involving macula in which we performed 27 gauge vitrectomy. So it is a retrospective cohort study that was performed at Shifa International Hospital, and the data was collected from between 4 years, starting in 2015, going up to 2019. And basically we included all the patients who had traction retinal detachment involving macula. So either just up to, or just starting to involve, or maybe 4 years completely off. And we excluded the patient who already had retinal surgery previously, or any buckling procedure, anything has been done. So one surgeon who did the surgery. So primary attachment with the one surgery, how much success rate we got. Secondary means that we required additional procedure to fix the retina. So I'll just show a couple of videos and then I'll go to the outcome. So initially we clear up the vitreous hemorrhage. So I also have got low threshold for cataracts. If there is slight cataract, I will go with and remove the cataract. So we are using the cutter either as a pick to lift it up and then cut it, go beneath, and we break all the attachments which are pulling over the retina. And once you are in the right space, your cutter can easily go through and remove the membranes. So I try to not to leave any fibrous tissue there. So as much as possibly I can remove safely, I would go for it. So you increase the bottle height if you're noticing some hemorrhages. And it's also important to cauterize if you're seeing that there is a major bleeding happening, so it's better to cauterize it. So gradually I'm going all around. And we remove the membrane. Regarding the tamponade, if a break is developed, usually my approach is to use the silicone oil in such cases. So here the laser has been done, we finish up the case. Similarly, in the next case, which is quite a bad traction retinal detachment, that's the only eye of the patient. And you can see all just a fibrous tissue, you can't see the disc. So here I decided to use a chandelier to do bimanual approach, that it would be easier. So first we did cataract extraction, that was once done. So it's a hybrid 27 gauge plus chandelier, I'm using the 25 gauge. So you try not to lift the retina much while you're doing it, to slightly creating the cleavage, you go beneath it and you start removing the membranes. So here we have found the cleavage, so I'm just going beneath that and removing the membrane. So once you are in the right plane, that becomes easier to remove. But say all the game of patience. So although 27 gauge has got the smaller port size, but if you do right cutting, if you go up to 10,000 cut, like in this case we are using bright vacuum, you are using, you can easily manage to remove even so extensive membranes. So here you can see that once, so now you can see the foveal and macular yellowish appearance there, so that's coming up. And as you are removing the membranes, retina is going back to its place, so it's lifted up. So gradually we are removing there. Hemorrhages, not to bother about, you can clear it later, but if it's a major bleed, as I already mentioned, you can cauterize it. So almost we are done. So we are removing the last bit again. And you can go up till the periphery, and once there, the membranes will become more easier to come off. So in such cases, most of the time, yes, you put the silicone oil, leave it. If everything is fine, later you can remove the oil. So here it was a very thin retina. Shortly you would see that there were tiny holes forming. Yeah, these one you can see there. So it's very important if there are breaks or holes there, remove the membranes completely around that. You don't want to leave it like this there. So once it's removed, I did ILM peel in this case as well. So once the ILM peel done, the fluid drainage, silicone oil exchange, and we finish up the case. So coming to the results, 196 eyes of 176 patients, and mostly they were male patients. Mean age was around 55 years. Most of the cases were under local anesthesia. We used modified retrobulbar block, 96%, and a small percentage was having general anesthesia. And combined phacoemulsification was and vitrectomy was performed in 64% of the patients. So usually the patients, diabetic patients who are bad, they have got some cataract there as well. So it's better to remove it at the same time. So that's a mean operating time, 90 minutes, and ILM peeling was performed in 23 eyes. So choice of tamponade, so mostly we left it here, but the reasonable number you are seeing that's under silicone oil as well. So if it's extensive, there are breaks there, I would definitely use oil in this case. And small percentage, we used SF6 or C2F6. So most of the patient, if you look here, 98% were attached with the one surgery. 3 patients required another procedure to fix it, and 1 patient developed vitreous cavity hemorrhage that cleared at its own later. Best corrected visual acuity, that improved from 1.86 mean logMAR to 0.54. So significant improvement in the vision. Complications, 1 patient developed suprachoroidal migration of silicone oil. So if you're, in this case, basically I wasn't using any trocar, so I tried to directly through the sclerotomy, injecting, because I think trocar, usually what I do is from 27 gauge, put the 25 gauge trocar when I'm injecting the oil, because it slightly becomes easier, quicker. And in this case, unfortunately, I didn't put it, and that led to migration of oil in suprachoroidal space, which most of the oil I removed at the same time. Later I went back after, I think, week. There was some vitreous hemorrhage, suprachoroidal hemorrhage as well, removed the remaining one, and patient had very good outcome. Vision is 6.9. Later we removed oil as well, and there was no suprachoroidal oil. Other transient rise in IOP, which managed anti-glaucoma treatment, as I mentioned, 1 vitreous cavity hemorrhage, which cleared at its own. So I think it's very a large sample size, minimal post-procedure complications, and good anatomical rate that you can achieve with 27 gauge vitrectomy. And I think it has shown that it is a safe and effective way to manage tractional retinal detachment. Thank you very much.
Thank you, Dr. Ahmed. It was an excellent presentation. So you think regarding timing between 27 and 23, you didn't find much of a difference, didn't you? 23 gauge.
I think, yeah, it is a difference. 23 and 27 gauge, it is different. One thing is definitely the port size is different. The shaft is more thicker in case of 23 gauge. But I would say once you go to the smaller gauge, either 27, 25, 23, whichever you are comfortable with, you can carry on. I use 25 and 27, so most of my work is with 27, like 70% or 30% I do with 25. So 25 and 27, they are almost like similar.
I mean, regarding the density of vitreous hemorrhage, you did not have any problem.
I haven't shown, I think I showed the videos on when workshop, how much thick here you can see membranes, you can remove it.
Okay.
It's just the right settings if you're using. If you keep your cutter open for a longer time, if you do the setting like that, you can easily remove it.
And
It's
I
no
think
problem.
you're
And
not.
higher cut rate. That
And
matters also.
I think you're not reusing the 20. You're only using it for 1 patient. You're not reusing it.
Well, I used for 2 patients.
Okay.
27 gauge. So we re-sterilize it. Basically, we do a re-sterile according to hospital protocol and then use for.
Yes. Okay. Yes. Please.
Yeah, regarding the suprachoroidal silicone oil, like, did you diagnose it on spot in the same time during surgery, or
Sorry, say it again.
the silicone oil, the suprachoroidal silicone oil you mentioned in the end?
Silicone insertion with?
No, the suprachoroidal silicone oil.
Yep.
Did you recognize it in the same time, like during surgery, or the next day you would follow up, you find the lesion, and how did you remove it?
I think what I did is basically because as you know that even at the trocar area, there was a separation there. So I was using the valve as we are using that thing. So that was bringing oil out. I put heavy liquid in to mobilize it so it can come further up. And the other thing is you massage it basically. And slightly I enlarged my sclerotomy as well at that area, and that helped to remove it. But as I mentioned, that some amount still was remaining. So what happens when you are finishing surgery, sometimes you say, oh, everything is done, just it's a piece of cake, and you were injecting. And I kept on injecting. And then when I realized that mound is coming up, so then I realized, so a lot of oil was in suprachoroidal space. But as I mentioned that later when I went in, there was some hemorrhage as well. So I did a scleral incision I gave around 7 to 8 millimeter from the limbus, and that helped to remove the remaining oil from that area. So, but I'm lucky enough that all oil, we are going to publish that as well. So soon it will come up in one of the Pakistani journal.
Thank you.
Thank you.
Yes.
Thank you very much for this lovely presentation. I mean, obviously, 27 gauge certainly is the time future, but the only thing, first carrying on from his question, first of all, for my own knowledge, how did you recognize and how quickly you recognize that the oil is going in the suprachoroidal?
Very
How
late.
did you recognize that?
Very late. So that's what I'm saying. But because what happens sometimes when you're putting oil, you're chatting with your colleague, assistant and thing, then you just think you're finishing. So only I realized when I saw that some massive thing is coming up in the pupil. Yeah, elevations I noticed. That was the time I.
How did you, I mean, how did you know whether it was not a hemorrhage but an oil?
I think because the hemorrhage wise, you can see the change in the color of that. So that wasn't there color wise. So I could see easily that it's just all lifted up. And then I looked at my area where I was inserting. I can see that all elevation is there. So
And the oil would not be going inside, and the oil would not be going into the vitreous actually.
well, it has initially it has gone in, but eventually yes. If it's not, then it's mostly what I was injecting that was going suprachoroid.
The other question is that how challenging, I noted that when you said, you're putting after 27 gauge, because I do use 27 gauge as well, but whenever I feel that I'll be using silicone oil, especially, and in complicated diabetic patients where I need to put in maybe sometimes 5,000, I obviously prefer 23 or 25. I don't go for 27 the first go because I know that I'll be struggling and I'll be sitting on the table for hours and hours. So is that the thing you also feel, or are you still happy with 27 and then you put, because it would be an extra maneuver to remove the trocar and put in 25 or enlarge the sclerotomy. So what's your take on that?
I think I never tried through the 27 gauge, but there are systems you can inject, but it will, especially with the 5,000, I think it would be much difficult. So what I do is I usually take the 27 gauge trocar out, put 25 gauge in, and insert from there. So even 5,000 I have inserted in few cases. It's not a
Do you
problem.
have separate trocars or you open a new
Yes,
tank?
I've got separate trocars, yeah, for 25 gauge.
And when you're removing the silicone oil, for example, in this case, which you had done with the 27 gauge, so what would you do then?
I think in those cases, basically, because mostly I use the 1300 stroke, centi-stroke ones. So mostly I remove with the 25 gauge, but yes, in some cases, what happens 27 gauge, if I'm using, I take it out from 27 gauge. It's not a problem. You can take it out easily with 27 gauge.
Okay, thank you.
Thank you.
Thank you, Dr. Usman. One more comment about the peeling of ILM. What would be the indication to do an ILM peel in those cases? Or some of the people are doing it in most of the
Yeah.
cases?
I think it's a good question. So ILM peeling, if I'm noticing that there could be any traction there over the retina, and sometimes what happens, basically you think that you have removed all the membranes, but actually some membranes are still remaining there. So when you put the dye, you can see that there are some membranes, or sometimes ILM has got tractional element there. So there is a traction there. So ILM is pulling over the retina in that area. When you put, you would see that the folds wise you will be seeing. So ILM peel gives you a guarantee
I mean, that traction or that element, you assess that surgically or intraoperative OCT or?
no,
I mean,
I haven't got a luxury of
what,
intraoperative
I mean, that,
CT.
what were the, I mean, you know, the points in deciding an ILM peel in those cases?
I think the point
Trick,
is I'm
any
saying
trick?
if I'm noticing that I feel that there is retina is over the macula, it's not looking as smooth to me. It's looking elevation, or even if I'm noticing that there is slight whitish membranes remaining the side of, so I would like to put in the dye to look for that any further membranes there and remove the ILM then along with that. Or even if sometimes there are patient has got the macula hole there, I
Yeah,
would
then you
remove
have
it.
to
Yeah.
actually. One of the first presenter, he was commenting that if you have removed in TRDs, if you have removed all the traction, but you still think that there is a little bit of fluid over there. So either you want to completely, you are in habit of draining it with a retinotomy, or it is all right with you.
I think if you don't have any breaks or anything, fluid gets absorbed, so it's not a process. You definitely don't need to do retinotomy.
Okay.
It's only if there is a combined dermatogenesis, or if you have got like cases where you developed etiogenic breaks. Yes, now you have got the break, you would remove it, but not necessarily in every case you do need to do retinotomy to remove subretinal fluid.
Okay. Thank you.
Thank you.
Any more question or comments? Okay. Okay. I just asked. Dr. Huma Kayani, I think I can't see her here. She has a talk on diabetic retract. She's not here. Ali Afzal Bodla, updates on surgical management. He's not here as well. Sayyid Fazal Shah, according to my record, he's talking on intraoperative OCT. So, Sayyid Fazal Shah, he's not here. Okay. So we'll just, I think, then conclude the session with the concluding remarks from. Okay, that's fine. So thank you very much. We can have a picture over here, all the speakers. Thank you.